So, hi everybody. It is my great pleasure to welcome you all to this educational activity in parallel to the COMy 2024 annual meeting. And the focus of this roundtable discussion is about the use of quadruplet combinations in multiple myeloma. And as you probably know, this has been really dramatic progress recently in multiple myeloma, where we've seen the advent of quadruplet prior to induction in the transplant eligible patient. We've seen also some beautiful data about some nice combinations, quadruplets, specifically in the high-risk population, whether they are transplant eligible or non-transplant eligible or so-called elderly. And last but not least, we've seen fantastic evolution and progress when it comes to the management of elderly non-transplant eligible myeloma. And in order to answer these three questions, it is my pleasure to have with me today Dr. Francesca Gay from Torino in Italy, Dr. Lisa Leypoldt from Hamburg in Germany, and Dr. Thierry Facon from the University Hospital of Lille in France. And Professor Facon is also my co-chair in the organization of the COMy Congress. My first question is to you, Francesca. Can you please give us an overview about the role of quadruplets today and what is the state of the art when it comes to induction prior to transplant in multiple myeloma?
Thank you, Mohamad, and thanks for inviting me here. And good afternoon to everyone. So I think quadruplets are now the standard of care for newly diagnosed and transplant-eligible myeloma. Quadruplets that include anti-CD38 monoclonal antibody, proteasome inhibitor, immunomodulatory agents, and steroids, as we have now more than one trial that show either the superiority in terms of high-quality responses and MRD negativity of induction with the quadruplet compared with the triplet, or even larger studies with longer follow-up that are also able to show progression-free survival advantage related to the use of the quadruplet, often as induction, pre-transplant, and post-transplant consolidation, compared with the triplet. So I think we have data on ISA-VRD compared with VRD showing higher rate of MRD negativity after induction. We have two studies, the Griffin and the Perseus study, exploring DARA-VRD versus VRD and showing the PFS superiority and not only MRD superiority for quadruplets over 3 drug regimens. And we are also starting to use backbones with different PI as, for instance, KRD, plus either daratumumab or isatuximab in different studies. So the ISKIA study compared ISA-KRD versus KRD pre-transplant induction and showed higher rate of MRD negativity with the quadruplet induction compared with the 3 drug regimens as induction, and this advantage is persistent after transplant and after consolidation. So to me, all these data show that there is no reason to give a suboptimal therapy up front. We should use a quadruplet. Which one, no one probably knows. We can discuss a lot which one could be better. Could be based on toxicity, expected toxicity, schedule of administration. But generally, in the transplant setting and in fit patients, we don't have too many limitations related to toxicity on the use of the different combinations.
Thank you very much, Francesca. You mentioned that quadruplet that should be given to everybody. So now my question is to you, Lisa. about this concept trial that you have led. And this is a trial which used actually a quadruplet induction, whether in transplant eligible or non-transplant eligible, but specifically in the high-risk multiple myeloma population. So can you please explain to us the rationale behind the choice of a quadruplet here, and what were the results in these two populations?
First of all, also hi from my side, and thanks so much for inviting me. I'm very happy to discuss these very interesting topics with you. And regarding to your question, Mohamad, so the concept trial is an investigator-initiated trial with solely high-risk patients, with the high-risk disease being defined by the ISS stage 2 or 3 in combination with high-risk cytogenetic aberrations, deletion 17p, translocation 414, 1416, and the amplification of 1q. The trial is a one-arm trial, but it has two treatment groups, if you want to call them so, for transplant eligible patients and transplant non-eligible patients, because so far or before the concept trial was initiated, it was still the era when RVD was given to everyone, or even VCD, and to the elderly only RD. And we have known from prior data that back then the median PFS and also the median overall survival for this high-risk population was only around 2 years. And so it was clear that we need something more efficient. And by integrating the with isatuximab is the CD38 antibody, and also carfilzomib is a second-generation proteasome inhibitor, which has shown to overcome also resistance against bortezomib in some patients. We just brought sort of the best agents first for this high-risk population with the unmet need. And I think the data, which has shown high rates of MRD negativity of almost 82% for the transplant eligible patients and 70% for the transplant non-eligible patients, has proven, together with the data from the ISKIA trial too, that particularly in this high-risk patients population, this quadruplet, including carfilzomib, proves beneficial with improved progression-free and overall survival.
Thank you very much.
And also just wanted to mention, because the oldest patient was 87, so included in this trial, that it is also feasible in the older population, and happy to discuss more later on.
Thank you very much, Lisa. My second question to you, Francesca, in the concept trial, in the high-risk population, they have used this isatuximab, carfilzomib, lenalidomide, dexamethasone combination, whether transplant eligible or non-transplant eligible. And the results are proving to be very appealing. So if it works so well in the high-risk population, obviously it should work well in standard risk. So why don't we recommend this kind of combinations in all patients? And for instance, the IFM French MIDAS or MIDAS trial used actually ESA-KRD for induction. What is your opinion?
I agree with you, and I very much like the MIDAS study. I'm completely in favor of the MIDAS study with the ISA-KRD induction for everyone. So the data are very good. I think the PI backbone carfilzomib works very well. Unfortunately, we don't have an head-to-head comparison of K versus B in the transplant setting, at least, showing the superiority of one over the other. So we can't say that one is better than the other, but we have a quite high rate of MRD negativity. So I think this quadruplet combination that is working very well based on the concept study in high risk can work as well, if not even better, in the standard risk. Of course, there is a schedule if you use the twice weekly or the once weekly, the way of administration, the potential cardiovascular toxicity, but we know how to manage it now. So I think we have data to try to use it not only in high risk, but also in standard risk.
Thank you, Francesca. Let's move now to the elderly or non-transplant eligible patient. And my first question is to you, Thierry. And maybe you can give us first an overview, a summary of the evolution of multiple myeloma therapy in the elderly population in the last 20 or 25 years or so, because it has been really a fantastic journey. And today it looks like that the outcome of elderly myeloma is proving maybe to be better than younger myeloma patient, because obviously it's probably better if we have to have myeloma to have it at age 75 and then take advantage of these advances rather than having myeloma at age 50, despite all the other advances. What are your thoughts?
Okay, regarding the last part, that could be a good discussion point anyway. But okay, so I am an old hematologist, as you mentioned, and we started with melphalan-prednisone. But you know, the IFM still published melphalan-prednisone in 2006, so that was the so-called IFM 95 study. And the control arm was melphalan-prednisone. Then after that, as you said, we developed the combination of melphalan-prednisone and thalidomide. We switched to lenalidomide and dexamethasone, then to daratumumab, lenalidomide and dexamethasone. And this year you will see at least one study having isatuximab in combination with VRD. So we did progress in elderly, newly diagnosed multiple myeloma patients anyway, and so that's true. Then as previously said, we have now several phase 3 studies in transplant eligible patients, showing that quad regimens improve the outcome of patients, and so you mentioned the ischia concept. There is the German myeloma study group study published in the Lancet Hematology, Perseus, of course, published in the New England Journal, and Cassiopeia is a quad regimen as well. So we have Griffin in the USA. So we have several studies in transplant eligible, and we have ongoing studies in transplant ineligible. So one is called the IMRO study, which will be the comparison between VRD and isatuximab VRD. The other one is the so-called Cepheus study, which is VRD versus subcutaneous VRD. And as an IFM doctor, I should add a third important study, which is called BENEFIT. So BENEFIT is an IFM academic study chaired by Xavier Leleu, and we did investigate. The control arm is isatuximab, lenalidomide, and dex, so an equivalent of DRD, let's say, and the investigational arm is isatuximab VRD with a VRD light regimen. So and BENEFIT will read out this year as well. So we will have something to say about quad regimens in the elderly. And okay, so that we will see, but then, you know, that being said, you have to go back to this concept of frailty, basically, because yeah, if you want to make this short, you could say that DRD is an acceptable regimen for frail patients. You could say it's a good regimen for frail patients. But on the other hand, at the time, we will move from 3 to 4 drugs. And it has been done in a Spanish study, for example, called the GEMFIT study, which was limited to fit patients, but still, so all fit patients are not the same, and the less fit part of this fit study, I would say, has shown some additional toxicities as well. So when you the conclusion might be, so we will see, but what is likely true is that there is a possibility to manage 4 drugs in, let's say, in elderly fit patients, but I would likely not recommend to use it in frail patients. And this is also reflected by the study designs. For example, IMROSE has excluded patients over the age of 80 years, and CEPHEUS has excluded the frail patients based on the International Myeloma Working Group Frailty Score. So if these 2 studies are positive, at the end, we may say, and if benefit is positive, we will say that quad regimens might be options for elderly fit patients or elderly non-frail patients, let's say, and that, okay, we will see, but that could be the way to go, basically.
So given the results of quadruplets, and you alluded, Thierry, to the IMROSE trial, which was announced in a press release showing the superiority of ESA-VRD over VRD. You also mentioned the so-called benefit trial from the IFM showing the superiority, at least the primary endpoint related to MRD, of quadruplet ESA-VRD versus ESA-RD. The question is, now quadruplets are likely going to be offered to everybody who is fit. And that raises the question of the value of transplant. Because it looks like, based on benefit, based on the ISKIA trial, based on the concept trial, one common denominator of all of this is the capacity of these quadruplet regimens to induce a deep response and sustained MRD negativity. So that brings me to the question about the value of MRD negativity in the transplant eligible, but also non-transplant eligible patients. Should this become a goal for everybody, for every myeloma patient to achieve? And you may have different opinions.
Ladies first.
Francesca.
That's a tough question. I think the value of MRD is recognized by every one of us. So we also know the recent opinion from the FDA in favor of MRD as an endpoint for study as well. So I think MRD should probably be the goal for the majority of the patients. We still don't know the depth of MRD, which is more meaningful, -5 versus -6, and the duration, more importantly, probably of MRD. So it's not only important to show a deep MRD, but also durable MRD. And in this regard, maybe the cytoreduction that you can get with transplant could be, in the end, more impactful on the long-term outcome compared with cytoreduction without transplant, but we currently do not know. We showed this in the era before the quadruplets. No one has shown it now in the context of quadruplet. There is still a small proportion of patients, this so-called MGUS-like, maybe they don't get MRD, but they have very long-term remission. So I'm not sure this is true for the majority of the patients. For sure, if you get it, it's important in many, many patients, particularly high risk, particularly high tumor burden, and so on.
Thank you very much, Francesca. Lisa, what is the knowledge which has been generated from the concept trial in relation with the achievement of MRD negativity and its impact on the outcome of patients?
Mm-hmm. So, I mean, the concept trial, as I said, technically it's not a 2-arm trial because patients were not randomized. However, if you just look at the pure numbers of patients achieving MRD negativity in the two arms, transplant eligible and non-eligible, really the only thing that differentiates the treatment is the high dose versus 2 additional cycles. And we do see about 20% difference in the achievement of MRD negativity, and both overall and also sustained MRD negativity for 1 year. So we do see an added benefit of transplant in this high-risk population. Remember, this is all high risk. So I do think that at least in high-risk patients, transplant still has its value. So with regards to the value of MRD negativity and high dose, especially in the high-risk setting, we could see that in the transplant eligible arm, the MRD negativity rates were about 20% higher, both overall and also with regards to sustained MRD negativity for the younger transplant eligible patients who received transplant, and in comparison to the older ones who did not receive transplant, but instead 2 additional cycles of ISA-KRD. This trial was definitely not two-arm comparison beneath each other, but I think it is in line with prior data which we have seen showing the benefit of transplant with regards to deepening responses and also progression-free survival in this high-risk population. More important, we could see statistically significant that the achievement of MRD negativity is associated with longer progression-free survival, and the hazard ratio of 0.118 was quite impressive, highlighting the need to induce deep MRD negative and also durable responses in this high-risk patient population. So I think for certain in this high-risk patient population, transplant still has its value because it deepens responses and therefore fully helps in maintaining longer progression-free and eventually overall survival.
Thank you, Lisa. I think we had some connection issues, but anyway, I'll direct my last question to you, Thierry, and whether in the non-transplant eligible but fit elderly myeloma patient, should we use MRD negativity as a goal for treatment?
You know, I agree with what was said by Francesca. Probably it's not good to say that we must achieve MRD negativity. If you get MRD negativity, it's nice and it's likely better for a particular patient. But she mentioned the MGUS-like patients. The same in a certain extent may apply to frail patients. So if you get a good complete response without MRD negativity in a very elderly and frail patient, that you may achieve a nice PFS, and this was shown, for example, with daratumumab, lenalidomide, and dexamethasone in the Maya study. MRD is an important endpoint, but okay, you probably cannot say that you must get MRD negativity. Regarding the role of transplant, I still believe that at the time we will be able to make some kind of, let's say, some kind of comparison between the Perseus and the studies done in elderly. You will likely see some difference in terms of MRD negativity. So in other words, you get more MRD negative patients if you put transplant in your treatment schedule. And so this is the reason why, from my point of view, transplant will remain on board for some years. It might be replaced by CAR-T strategies or something like that, but I still believe autologous stem cell transplantation is something important for the younger patients.
Thank you very much, Thierry. Thank you very much, Francesca. Thank you very much, Lisa, for sharing your opinion, your experience, and congratulations for the wonderful studies you have run and we have discussed, namely the ISCIA trial, the IMROSE, the concept, and many others. It has been a pleasure having you with us. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you
Bye.
so much.